Tell us about the management of cardiac AEs associated with BRAF MEK inhibitor therapy. When managing patients who are on BRAF and MEK inhibitor therapy, there are basically two kinds of cardiac events that we need to be watching for. One is QTc prolongation, which is generally associated with vemurafenib solely. The other is a class effect of the MEK inhibitors, which is decreased left ventricular ejection fraction or cardiomyopathy. I'll start with the management of QTc prolongation. With patients who are going to initiate therapy with vemurafenib, we generally recommend getting a baseline ECG and then reinitiating or redoing an ECG at 2 weeks and then 1 month for the first 3 months. Also, up front, prior to starting your patient on vemurafenib, we recommend a very close interrogation of their concomitant medications, including any over-the-counters or herbal products, as there are many drug-to-drug interactions that can increase the QTc interval. Generally, we need to hold vemurafenib for any QTc greater than 500 milliseconds versus any increase of greater than 60 milliseconds once drug is started. Again, if your patient has an increase in the QTc falling into these categories, definitely need to reassess and make sure that they haven't started any new medications per their primary care or on their own. And then we will watch them closely, repeating ECGs until that QTc has normalized or is back to their normal starting. Then we will usually try to re-challenge them with vemurafenib. The second cardiac adverse event that we really need to monitor for is a class effect of the MEK inhibitors, which can cause decreased ejection fraction and or cardiomyopathy. Careful history taking is imperative in this patient population, making sure that they don't have any history of congestive heart failure or an idiopathic cardiomyopathy. We also want to get a baseline echocardiogram prior to starting therapy, and then again at 1 month, and then every 2 to 3 months while patient is on therapy. Additionally, if patients do have an ejection fraction that is decreased, most of the time this will be asymptomatic. However, we really need to watch this, and if this drops below 10%, then we generally will need to hold therapy until that recovers. For patients with a symptomatic drop in their ejection fraction, which can include shortness of breath, peripheral edema, chest pain, we need to hold their medication and also work with our colleagues in cardiology at this point. For any patient that does not have recovery of their ejection fraction within 4 weeks of a dose hold, they need to have their MEK inhibitor permanently discontinued.